Good morning, everyone. Welcome to the Wise Incubator virtual conference.
Morning, Mirna.
Good morning.
Good morning, Mirna.
Good morning. Thank you for joining. We're very excited to have you join this this event. It has been very exciting to work on this project over the past few months, and today we will have 4 presenters. I will move on the slides to continue with the presentation. Okay, so the agenda for today is that we will cover some guidelines on how we will work through this virtual conference. We will have our CEO and President, Ana Rita Gonzalez, present some welcome remarks and talk to us about policy wisdom as well as about this initiative that we launched in last quarter of 2016. Our winners of this challenge will have a chance to present their projects. We have 3 presenters, Giancarlo Atassi, Jiaying, Cheng, and Ma.Sophia Reyes. We're very happy to have you in this, be the participants and winners and be presenting during this virtual conference. After each of their presentations, we will have a chance to make some questions to them. And we will close the session with questions and comments. Okay, so in terms of the guidelines for this call, when you join the call, you should be, first of all, the conference is being recorded. It will be available through our website for anyone that wishes to go back to it and or people that didn't have a chance to join at this time of day. So it will be recorded and available through our Policy Wisdom website. Also, we are almost all of us are muted. Some will have some presenter rights given at some point in time. So if you are not muted for any chance, please do so we avoid the background noise. And if you need to step away of the meeting, please do not place it on hold so that we don't get background music or disconnected. All lines will remain on mute except those of presenters. As I mentioned earlier, there will be an opportunity for questions and answers after each of the participants presents their project so that we have our questions fresh in our minds after each of the subjects. The questions or the comments that you may have, you should send them through the chat. You will see a little comment bubble where you can write in your question, and our team will be checking on those questions, making sure you have a chance to ask and also get a response to it. And also on this presentation, there are references that the participants included and additional explanatory slides that will not be covered during the presentation for the sake of time, but that will be available on the online versions that will be uploaded also in the Wise Incubator website. Okay, so now we can start our meeting with welcome remarks from Ana Rita Gonzalez.
Thank you, Mina, and welcome to everyone that joined the conference. I have to be honest that this is like a dream come true for me. As being a passionate public health and policy person, I feel that being at a point in which as a company we can bring young and new minds that are studying public health to make a contribution to new ways of thinking about innovative policies definitely is a dream come true. So I'm extremely happy to be in this virtual conference, and I welcome all of you. And I'm also very excited to see that we have representation from every continent of the world in the conference. So I think the passion is global. Basically, if you can help me, I want to give you a little bit of background on who we are. Policy Wisdom was founded in 2010, and we are a company solely dedicated to changing and influencing public health policies with the vision that someday we will be able to say that we had a role in every important public health policy that is improving the world. We do this through evidence-based solutions and through helping our clients to see exactly what is the best way of influencing policies so that we make a positive impact in the world. We have over 25 clients, many products to bring that evidence to life and to develop good strategies, and we have worked around the whole world. And I'm so proud to say that we have a group of more than 30 professionals that come from many different walks of life, many different skill sets, many different professions, and also many different cultural and social backgrounds, but we all have in common a passion for public health policy and a passion for evidence. And then together we help our clients be the same way. So in the next slide, we want to talk a little bit about what is the Wise Incubator. As a team, we have wanted over the years that we have been in existence to make sure that we give back. The first few years, we give back to an orphanage in Argentina. A couple of years, we gave back to a favela in Brazil. And we felt, so now we're ready. We're a more mature company, and we want to do something that gives back to the people that are starting to work in the public health arena and in policy, and that at the same time gives them a platform to really exchange and talk about innovative ways of changing policies and changing public health. So a year ago, we started thinking about this, and we created what we call the Wise Incubator, basically to address health challenges, and we've decided to address these challenges in very important spaces of equity, access, protection, and sustainability, and to have public health students, graduate and undergraduate, have an opportunity to link theory to practice and submit projects that describe novel policies. We're so excited that this year we have 3 winners, Giancarlo, Jiaying, and Ma.Sophia, and we will hear from them, and that they came with innovative solutions that really match our tough criteria and match the desire to have new ideas. So again, welcome all of you to our first virtual conference, hoping that this will be the first of many virtual conferences. And I'm as excited as you all are to hear from our presenters. So Mina, thank you so much.
Okay, thank you, Anarita. We're going to talk a bit about each of our presenters and the projects that they will present. We're very honored that these students really took the time within their very busy study schedules and multiple responsibilities to participate in this initiative. And the subjects are very different, but all very relevant to the public health field. I want to talk to you about each one of them briefly. Giancarlo Atassi, he completed a Bachelor of Science at the University of Miami, majoring in neuroscience and religious studies. And he's going to complete his master's in May in public health with a concentration on global health at the University of George Washington University. He's also going to be enrolling in medical school this coming fall, 2017. Has a very tough decision to make whether 2 great universities, University of Miami or Northwestern University in Chicago, so he will decide by the end of May. For his master's practicum, he's currently working with United Health Partnerships, which is a nonprofit public health policy consulting headquartered in Miami, and that provides technical assistance on projects relating to community health, building environment and linkages to health, and health policy in general. Giancarlo is a second-generation Syrian immigrant, and as a global health component of his career, he would like to return to Syria one day when the fighting has settled down in that country and use the skills gained through his public health and medicine degree to help rebuild the healthcare system in the country. Jiaying Cheng, she's enrolled in the Master of Health Sciences program in the Department of Environmental Health and Engineering at Johns Hopkins Bloomberg School of Public Health, and will also be graduating next month, May 2017. Before joining public health field, she completed an undergraduate degree at the School of Architecture at Tsinghua University in Beijing, China. Her current interest focuses on population environmental health, including using epidemiological methods to link point source environmental pollutants to adverse health outcomes, particularly focusing on chronic diseases. She's evaluating her next career steps, which may include returning to China and applying her education in her hometown. And with the background and experience gained through studying these two disciplines, she looks to improve and achieve a better balance between built environment and environmental health. And last but not least, Sophia Reyes, she's a senior undergraduate student working towards her bachelor's degree in public health at the University of Manila, of the Philippines in Manila, the College of Public Health, and will also be graduating this summer. Her undergraduate thesis looks into the factors associated with the willingness of parents to avail of a dengue vaccine for children. Her interests lie in health systems and health service delivery, as well as delivery of health education. After completing her return service agreement for 2 years in the Philippines as required, she plans to do research and medicine abroad, primarily the latter, with a focus on health policy and systems. She believes that health is a human right, and her dream is to learn as much as she can and become the best public health professional she can be, and apply what she will have learned back in the Philippines in order to improve health outcomes across the country, make health accessible to all, and unify the health system. So as you can see, we have three outstanding young professionals with very diverse interests, but very targeted towards our goal, which is advancing public health. So with that, I think we have a great background to start with the presentations of our winners, beginning with the presentation from Giancarlo Atassi. We will grant presenter rights to Giancarlo so that he can continue on with his presentation.
Okay, excellent. Can everyone hear me?
Yes, we can hear you.
Excellent. Well, thank you, Marina and Anarita, for those welcoming remarks and that introduction. I'm very glad to be here, and I'm thankful to all of you for being able to attend. So with that said, let's get right into it. So my project is called Implementing Task Distribution to Decrease ER Visits and Hospital Admissions. And before I get into the actual intervention, let me just give you some introduction on the healthcare landscape in Florida. Florida is going to experience a shortfall of about 3,060 primary care physicians by 2025. It's only meeting about 41.25% of its primary care needs at the moment, and it has 258 primary care health professional shortage areas, and that is the second highest rate in the country. And the public health impacts of that are, of course, decreased preventative care, worsened clinical outcomes, and particularly excess spending. So, what's been done so far in Florida? Current legislative efforts have focused on a number of initiatives. New medical schools, 4 of them have been opened in the last 17 years. That's Florida Atlantic, Florida International, Florida State, and then Central Florida. There is the Startup Bonus and Retention Program, which created and funded old and new residency slots for more primary care and other specialties that are expecting shortages. And then there's also telehealth efforts. Legislative efforts have focused on studying the effects of telehealth on bringing down costs and that sort of thing. And then finally, there's also task shifting and redistribution that we're seeing, where legislators have recently passed bills to allow for physician assistants and nurse practitioners to prescribe controlled substances and, sort of expanding their scope of practice. Now, there's several limitations with all of these efforts, and in particular, opening new medical schools and opening new residency slots still does not deal with the market incentives that prevent students from actually going into primary care, such as increased hours over other specialties and decreased wages in comparison. Telehealth efforts are great, but they disrupt the doctor-patient relationship and continuity of care. And then with task shifting and redistribution, they're great steps in the right direction, but there's no organized framework yet in which physician assistants or PAs can practice solo or unsupervised. And so with that, I'd like to talk about my proposed solution, which is task redistribution, or as you may have heard it, task shifting. Now, the intervention name is called Florida Community Health Teams, or FCHT. The proposed intervention is actually fairly simple. We're going to recruit 16 physician assistants and form primary care practitioners, and I'll explain the numbers in a moment, and embed them directly in specified locations within the target population's area to work out of these small primary care clinics right in the neighborhood. And we want to provide free primary care to uninsured residents and to Medicare Medicaid recipients. And we want to build in a small copay for all others. And the target population that we've selected to pilot this intervention is the residents of the 33125 Miami-Dade County zip code. And that is a primary care health professional shortage area right in the heart of Miami. And here, just to give you one statistic, 55% of the target population receives Medicaid, compared to a national average of 21.23%. And we know already that Medicaid eligibility correlates with poorer health status. So we can assume that, the area has poorer health status. And so this is just for those of you unfamiliar with task shifting, this is a little description or diagram that kind of illustrates it. And you can see this is for HIV/AIDS treatment in particular. But you can see that on the left side, you have doctors handling some of the more basic tasks. And then on the right side with task shifting, you expand the scope of practice of nurses, of expert patients and peer educators, and of clinical officers, which in our setting would be physician assistants and registered nurses, to really handle those basic tasks and to let doctors handle the more advanced or complex cases. And so just to explain the numbers that I had mentioned earlier, Florida Statute 458.347 essentially says that physicians can delegate tasks to physician assistants as long as they're being supervised directly or indirectly. Indirectly can also count as, being easily accessible via mobile phone or internet consultation, but each physician can only supervise up to 4 PAs at a time. And so in order to be able to cover about 60,000 residents, which we rounded up, we decided on 20 practitioners, leading to 4 primary care physicians to supervise and 16 physician assistants. And so the intended outcomes, we want to see decreases in risk factors for non-communicable chronic diseases. We want to see decreases in the use of the emergency departments for non-emergent care. And we want to see increases in having a usual source of care in routine checkups and in vaccination rates. And just to talk briefly about what inspired this was actually inspired by 2 different sources. And the first was the Cuban Family Doctor and Nurse Plan, and the Cuban healthcare in general. And basically, just to break it down real quick, Cuban healthcare works with primary care doctor-nurse teams being embedded in neighborhood clinics and working there to improve the neighborhood health and, bring out vaccinations, provide antenatal care, that sort of thing. And it's been very effective. They have a 98% coverage rate for children under the age of 5 in terms of vaccination, and they have universal primary and antenatal care, and they have a lower mortality rate than the United States, actually. And then the second inspiration was alternative models of primary care in the United States, like urgent care centers and retail clinics. These are highly valued by low-income individuals because they provide this easy source of care, often outside of business hours, but they also tend to be located in higher income neighborhoods, making them, or creating another access barrier to low income. Now, how are we actually getting people in with this? In the FCHT service program, it's very similar to the National Health Service Corps. It's going to be administered through Florida's Agency for Healthcare Administration, and like the National Health Service Corps, you can see here it guarantees both loan repayment and a flat salary for physician assistants and a higher flat salary for primary care physicians. And we have 2 different ways we can possibly fund this. Number 1, the Florida ACHA does fund innovative primary care initiatives, and they have a specific trust fund set aside for that. And then number 2, advocates are pushing for a $1 increase in the cigarette excise tax at the moment. And we know that low-income individuals are more prone to smoking and other substance use behaviors, and that they suffer from poorer health outcomes as a result. So we would aim to earmark some of that excise tax for this program. Now, how are we going to make the program sustainable in the long term? Well, we know already that the state absorbs healthcare costs in the status quo. As we said earlier, 55% is on Medicaid, the majority of the remainder is uninsured or on Medicare, and then very few have private insurance. So we know that the state's absorbing the healthcare costs anyways. The program's going to result in decreased hospital admissions, unnecessary ER visits, and costs of care for preventable chronic conditions that nobody ever ended up addressing. And so 2 examples of this, just to briefly overview. The program, if it could bring the number of hospital admission rates for Medicare recipients down to the national average, it would save us $225,000 per 1,000 Medicare recipients in the area. And then for every person in the area who is diagnosed with diabetes at age 40, that's $125,000 in lifetime spending. And for every case that we can eliminate of that, that's $125,000 in savings. And then, of course, using physician assistants instead of primary care providers helps us keep costs down due to the lower salaries. And so what are the action steps, just very briefly? You can group the first 4 essentially as rallying support. First, we get the community. Then we get the city and health department on board. Then we're getting the physician assistants on board. And finally, we approach the primary care providers with all of this, and we get them on board. Now, the next step, we're going to secure the funding from the HCA. And then after that, we're going to recruit our primary care providers and primary and physician assistants. And then next, and this is a really important step for us, we're going to connect them with the community, with a steering committee from the community made up of community leaders and members to geographically plan out the locations of the service providers so that no resident within the community is more than walking distance away from a provider. And we think that this is crucial for maximizing access. And walking distance we're defining as approximately 0.25 miles, a quarter mile. Once we have our location selected, we will select viable properties around the areas or near the areas, renovate them into small medical offices, recruit our non-clinical administrative people, begin the program, and we also want to evaluate. We want to do a 1- and 2-year post-intervention evaluation, outcomes and impact evaluations to make sure that we're actually saving money and increasing access to care. And then briefly, some barriers to implementation. We'll have pushback from the Primary Care Providers Association. They may not want to cooperate because it might be seen as expanding physician assistant scope of practice. But we need to emphasize that this relieves the burden of primary care, alleviates the shortage, and still keeps physician assistants within their scope of practice. Funding, they may not wish to fund the program given the upfront costs, but as we've shown already, we can push program sustainability and cost savings to get over that barrier. And then lack of community utilization. Community members may not wish to use the services. They may not trust or know enough about them. So for that reason, we'll engage community leaders to really spread the word about it. And so just in conclusion, just to wrap up, Florida is experiencing a significant primary care shortage and lack of coverage. We've already gone over why the current solutions are inefficient. And so Florida Community Health Teams, it's community-centered intervention that's going to use task shifting to maximize access to care. And as we've already seen, we'll see program sustainability through reduced ER admissions, hospital visits, and preventable chronic conditions. And so it really provides us an opportunity for the state to test this alternative decentralized model of healthcare, similar to the Cuban systems and providing access similar to the retail clinics, while minimizing costs and maximizing access for vulnerable populations. Thank you very much for your time.
Thank you very much, Giancarlo. Very, very thorough study. Do we have any questions?
I have a question, Myrna. This is Jordan.
Thank you. Yes, we can hear you, Jordan.
Okay, great. Hi, Giancarlo. I've really enjoyed your presentation and also getting to work with you a little bit leading up to this. And I just had a question about the Cuban model that you found. Did you, looking into that or when you discovered that Cuban model, did you discover or learn about any implementation barriers that they had in Cuba in implementing this program that should be considered and avoided when you're trying to implement in Florida? Obviously, there are very different marketplaces, Cuba and the U.S., and I'm just wondering what considerations you might need to take into account for implementation here in the States.
No, absolutely, and that's a really great question. Thank you for asking it. So It's not actually a barrier for implementation. The primary one I'm thinking of, it's not actually a barrier for implementation on the Cuban side, but it would be on the American side, and that is the fact that Cuban doctors and nurses are significantly underpaid relative to their actual skill base, and they can get away with that because the medical care is so subsidized and it's all very tightly government regulated. Not the case over in the United States, and so that is why this is going to be a pilot intervention. We understand that we're going to have to pay significantly more than the Cuban government in order to pull this off. And so we really need to track tightly that cost savings and see. We think that the Cuban model is interesting for its outcomes, but we also need to make sure that it makes sense in terms of the costs. And we expect that it will due to the cost savings and sustainability, but we do need to pilot that first. And I think that's the biggest barrier.
Okay, thank you.
Mm-hmm.
Thank you, Giancarlo. We also, I'm sorry.
Yes, this is Ana Rita. I also added a question on the chat. Giancarlo loved the presentation and the idea, and living in Miami even more, because I understand where you're coming from. But my question is, do any policies or regulations need to be changed in the state of Florida or in the city to be able to have alternate healthcare providers treat these audiences?
No, absolutely. That's a great question. And to my understanding, and this was actually when I mentioned the task shifting earlier, the task shifting initiatives, this was actually a very helpful piece of it, was that they deregulated control or prescription of controlled substances such that mid-level providers can actually prescribe controlled substances. And that was, I think, the last major barrier to allowing physician assistants to practice fully independently as long as they're being supervised. And so that is why this is such an effective intervention, because the mechanisms are already built in. It's essentially just that they haven't been used in such a way yet, where the physicians delegate their duties to these physician assistants and allow them to practice semi-independently, but supervised within the framework of the physician.
Thank you, Giancarlo.
Mm-hmm.
Wonderful. Thank you so much. Any other questions? We have a couple of seconds before we move on to our next presenter, Jiaying Cheng. Okay, I don't think we have any more questions. Andres, can you move over the presentation, give presenter rights to Jiaying? Thank you.
Okay, hello everyone. My name is Jiaying Cheng, and today I'm going to talking about a topic towards the environmental health protection. And here you can see there's a question here. A long-term low-dose indoor air pollutants are threat? Sorry. Well, you may be impressed, but it's true that people spend 90% of their time indoors. And on one hand, most scientific researchers focus on high-dose indoor air pollutants. Well, it makes sense because they need the high-dose indoor air pollutants to know some acute results. But on the other hand, there is a lack of guidelines addressing the low-dose indoor air pollutants. So we can see that here is a gap here between the doses. So here is the question. A long-term low-dose indoor air pollutants a threat? Well, to deal with this question, because the question is so broad, we need to clarify our target population at first, which is the family unit. Well, a family is most likely to own a house and spend significant time in this house. And it's very common for a family to own some wooden furniture. And the families with infants and those who live in newly decorated houses are more sensitive and susceptible to pollutant exposure. And here, because we are talking about several kinds of indoor air pollutants, we use formaldehyde here to provide a case study here. And as we all know, that formaldehyde is a common and major indoor air pollutant. The common dose for formaldehyde in scientific researchers is about 32 microgram per cubic meter. But the indoor air formaldehyde guideline is only 0.08. So you can see here there is a huge gap here because the researchers focus on so high dose formaldehyde, but the guideline for the indoor air formaldehyde is only 0.08. So we will use the formaldehyde to provide a case study for my further policy alternatives. And for my policy alternative, I will talk about 3 main sections. The first is how to remove or prevent the formaldehyde source. I think a labeling system should be introduced. And the second section is how to improve the surveillance system. I think the certification from a third-party agency should also be introduced. And the last section is how to distinguish the stakeholders. The point is to identify and gain the consensus from the key stakeholders. And I will talk about these 3 policy alternatives in more details in the afterwards slides. Okay, and this is the first section, how to remove or prevent the formaldehyde source. Well, we think a labeling system should be introduced for consumers to understand the risk. And the point of removal and the prevention of the formaldehyde source is that we think it is the most effective way to control the source. But, we cannot just simply remove the source because sometimes we need the wooden furniture. So how to deal with the problem? We think the labeling system could be introduced. Like the case here, we can find there is a dose range rating system here. And like the example here, the chair with the rating B plus the table with rating C can get a total rating of B minus. So like the cases here, we can use the dose rating system to know the quantitative and the collective formaldehyde emission dose. And then we can know how much formaldehyde will be emitted from the source. Okay, here is the second section. It's about how to improve the surveillance systems. Well, the point is that the policy landscape right now lacks surveillance systems for newly decorated houses. So we think to deal with the problem, we need a certification from a third-party agency, such as the EPA, the United States Environmental Protection Agency, or the CDC, the Centers for the Disease Control and Prevention. And how will we deal with this problem? We think there would also be a grade rating system like the cases here. We can also use the color and the grades to demonstrate the grade of the formaldehyde. And it's just a surveillance system for the long-term exposure, and it will make sense because you will know how much formaldehyde will be emitted for the long-term exposure. And it may be voluntary for the manufacturers at first, but you can imagine that for the long-term period, they also need the grading system to show that they are safety confirmed. So it may be voluntary at first, but we can imagine that with the development of the grading system, there are more and more manufacturers will use the grading system to show that they are safe, and the safety grade system will be popularized. And here is the last section, which is about the stakeholders. And we can see that the yellow circle here demonstrates our question. Are long-term low-dose indoor air pollutants a threat? And besides the yellow circle, there are 4 stakeholders: the furniture production industry, the public, including the heavy industry workers, the scientific research community, and the regulators and the policymakers. Well, the key point of the distinguished stakeholders is that we need to know who should take the responsibility, and we need to balance the conflicting pressures in the concerns of environmental quality. And we can suppose an example here. Well, the scientific research community can provide some theoretical basis for the regulators and the policymakers. And also, the furniture production industry should also provide some safety occupational environments for the public, especially for the heavy industry workers in the concerns of occupational health. So you can see here there are 4 stakeholders, but it's a very simple way for us to distinguish them. And the key point is for us to know that who should take each responsibility. And it's also an efficient way for us to deal with the problem, to know who takes the responsibility and who should take the responsibility to deal with the problem. Okay, here is the slide for the highlights here. And today I'm going to talk about the low dose long. We use the formaldehyde to provide a case study here. And the question is about the gap between the doses among the scientific researchers of the high dose indoor air pollutants and the low dose of the indoor air pollutants of the guidelines. So to deal with the problem of the doses here, we propose a question. A long-term low-dose indoor pollutants are threat, and we think that it may be a threat, but although there are not so much sufficient evidence to talk about the long-term low-dose indoor air pollutants, they are still a threat in the risk management. And as such, indoor air regulations needs to be improved. And that's all for my presentation, and I'm very welcome to the questions. Thank you very much.
Thank you very much, Jiaying. Very, very interesting, and the focus on environmental health is one of, I think, of importance to population in general. So in terms of your project, when you mentioned the stakeholders, who or where do you think you might get the most significant pushback or resistance regarding this certification approach that you presented?
Oh, thank you. That's a great question. Well, to my understanding, it may be the manufacturers, because currently, as I have said before, there's not a sufficient surveillance system. And the point of the manufacturers is to make money, to make some profits. So they don't care too much about occupational health or the formaldehyde emission. So it may be something with their problems because they want to make more money. So they will not put the safety as their priority. So they may make some high-dose formaldehyde emission furniture to make more money because the furniture can help them to earn some profits, but they don't care about how much formaldehyde emissions from their furniture. So it's a problem here because currently we lack a sufficient surveillance system to know how much formaldehyde is emitted from their furniture. So there may be some problems here.
Yeah, thank you. Thank you so much. We also have a question from Tina from Brazil. Are there any supranational guidelines for low dose, for example, from the World Health Organization?
Oh, thank you. That's a great question. The question here is very broad, and let me just take formaldehyde as an example. The guidelines for the indoor formaldehyde is under 0 per cubic meter, and I don't know whether it's come from WHO or some agency, because I searched for the conclusion from the online website, and I thought it was from EPA in US, but I'm not sure about the agency for all over the world. And in China, there's also a 0.08 for the guidelines in China, but it's also from the Chinese law system. So that's a good question about the worldwide agencies to do the guidelines, but I'm not sure currently whether there is an agency for that.
Yeah, that would be something interesting to go about. Okay, so thank you so much, Jiaying. I think we can move on now to Sophie's presentation.
Okay, thank you very much.
Thank you. Have a great day. Sophia, you have presenter rights.
Hello, good evening. Okay.
Yes, we can hear
Hello,
you.
so thank you again for the introduction. My intervention revolves around health human resources, specifically why the Philippines needs an institutionalized public health workforce. So my intervention is entitled Professionalizing the Public Health Workforce to address the gaps in the Philippine public health system. So first of all, I'd like to start by highlighting 3 key messages that should encapsulate my presentation. So first off, the Philippine public health workforce needs to be institutionalized as a complement to health system reform efforts due to the maldistribution in the healthcare workforce and a fragmented healthcare system, which I will touch on more later. Secondly, institutional and instructional reforms will be necessary in building the competencies of Filipino public health professionals. And finally, better management of human resources for health will need to be supported through intersectoral collaboration. So I'd like to touch on the landscape of the Philippine healthcare system. So what exactly is the problem? So the Philippine healthcare system is decentralized, meaning the service functions are dropped down to local government units, while the Department for Health is responsible for national policy direction. However, because the responsibility for direct delivery of health services lies with the local government units, this results in varied quality of healthcare across the country. Next would be health worker maldistribution. The Philippines is a major exporter of health workers. However, we face a critical shortage of healthcare professionals, especially in poor rural areas. There is an inability to attract and retain staff in underserved areas, and one reason would be due to a salary standardization law, wherein it is stated that those working in rural areas would be given a less salary than those working in urban areas. Due to this, there is a vacuum in the healthcare system, where the majority of the health care workforce choose to work and live in urban areas. These factors lead to a fragmentation of the healthcare system. There is a disconnect between sectors, and there are varied health priorities. These are all challenges that hinder the achievement of universal health coverage, which is actually the health agenda for 2016 to 2022, which is all for health towards health for all. The strategies are there, as you can see in the slide, but the question is, who will perform these tasks specifically? In the next slide here, you could see the structure of the DOH, and it shows that at the bottom you have a very public health centric structure. At this level, it may seem like it is the priority. However, there is a lack of professionals who work in health policy, health human resource management, and other core public health services. There is also a skewed focus on clinical as opposed to preventive training for health professionals. As in the Philippines, there are only around 1 or 2 schools that offer public health courses, majority focus in medicine and nursing, more clinical functions, and role confusion occurs for those who end up as public health professionals once they get into the workforce. So now talking about the public health system itself. So public health education in the Philippines is an ill-defined problem. In the Philippines, there is a mix of medicine, medical technology, and limited public health content. In our curriculum itself, we only have a few units, half a semester of health policy and administration. Most of our subjects are more focused towards medicine, anatomy, physiology, medical technology. and a small fraction of education is dedicated to practical experience and public health exposure. This leads to an unclear niche and confusing role once public health graduates enter the workforce. The Department of Health has a public health associate deployment program. However, those who apply to this program aren't necessarily public health graduates, and therefore there is a job mismatch with the skill set of current public health graduates. This role confusion leads to stress and lack of participation in the public health workforce. Because this role is not established in the healthcare system, doctors and nurses in the barrios or in the local government units are not sure what to do with these public health professionals once they get there. And so these public health professionals end up doing very limited work at all. The lack of clarity as to where a public health professional fits in the healthcare system, especially for entry-level public health graduates, makes it almost impossible to be competitive. So now moving on to the public health intervention. So this public health intervention aims to address the gaps in the public health system as described earlier. These reforms are based on a framework from WHO, World Health Report 2006, from entry-level solutions to workforce interventions. So firstly, we will, sorry, there's a problem with the slide. Firstly, we will do planning and building of institutions, and then an insurance of quality education, and moving on to recruitment of the workforce. So first of all, in planning and building of institutions, institutional reform and instructional reform need to be done side by side. So for institutional reform, there is a lack of interconnectedness among public health schools and among sectors. Philippine public health sector needs to be aligned with the global plenary to give credibility to the profession, and the gap between the academe and the workforce needs to be linked to ensure an effective transition of new graduates. This could be done through the creation of an independent public health professional organization or association whose functions would be aligned with the global network of public health associates, the creation of a healthcare education council or a supervisory organization, which currently does not exist, to bridge the gap between the public health academe and the workforce. And finally, research support. So the mandatory turnover or creation of a Philippine Journal of Public Health to the new supervisory association. So next we have instructional reform. So the curricula of undergraduate and graduate public health programs in the country are quite outdated and not standardized. So it is unclear if these curricula are in line with global standards for public health. So curriculum change, development, and standardization across institutions should be done to provide students with the opportunity to fully appreciate public health and its relevance in healthcare. This could be done through a mandatory adjustment of undergraduate and graduate program curricula to the 10 essential public health services as defined by the Centers for Disease Control, a nationally standardized and competency-driven curricula based on adapted core competencies and skill sets for public health professionals in the Philippines, a shift towards a transformative and liberal education style where problem-solving and professional and practical experiences will be incorporated, and supervision by a professional board of public health professionals. So next we have insurance of quality education. So there is a need for a metric system for quality assurance, which can be achieved through the adoption of standardized accreditation procedures for public health professionals by schools, programs, and institutions. To ensure quality education, accreditation could be done by official recognition by the Commission on Higher Education for a public health professional association to accredit these schools and programs, coordination with the existing public health schools in creation of criteria for accreditation, and adoption of international accreditation criteria for public health schools through international partnership with a public health regulatory body such as the US Council on Education for Public Health or the UK Faculty of Public Health. Finally, we move on to recruitment of the workforce. There is a need for incentives to continue into the workforce after graduation, because currently graduates are not sure whether it is necessary to get into public health or just continue into medicine, as that is what the curriculum dictated. We have interdisciplinary and inter-stakeholder engagement for the understanding of the value and cost effectiveness of a public health professional across all sectors, since as we all know, public health is multidisciplinary. We have an updated position classification scheme of the Philippine Civil Service Commission, so that the Philippine public health professional can be recognized as a distinct member of the workforce and subsequently receive better incentives and compensation. And finally, we have continuing professional development for public health professionals. There needs to be a niche for public health professionals through coordination with the Philippine Regulatory Commission, as stated above, and adoption of international public health core competencies. In order to have role identity insurance, we could establish a tiering system based on adopted core competencies, as well as areas where public health professionals could assimilate, such as within health service delivery, public health professionals in organization and management, and public health professionals in health policy and health promotion. And finally, we have assimilation into the workforce, wherein a linkage between the school or program for public health, the supervisory public health education council, and a government agency or supervising association in all regions of the country could be done for immediate but optional association or optional absorption into the workforce. Lastly, we need recognition and support of the public health profession. So once again, I will tackle the key messages for my presentation. So hopefully it was established that the Philippine public health workforce needs to be institutionalized as a complement to health system reform efforts. Institutional and instructional reforms must be necessary in building the competencies of Filipino public health professionals. And finally, better management of human resources for health. This needs to be supported through intersectoral collaboration and stakeholder management. So thank you very much for listening.
Thank you, Sophia. We have a question from Maru. It reads, the lack of capacity and unequal distribution of human resources for health is a huge global health problem. Building the public health workforce versus a strictly medical workforce could even be a more cost-effective solution to the country's health challenges and for meeting universal healthcare goals. Could this be a good message to get to the government so that they change the policies on this?
Oh, yes, it is definitely a great message to get to the government, especially in the Department for Health. Majority or all of our past secretaries for health have been medical doctors. And this is not to say that there's anything wrong with the medical profession. No, but there needs to be more focus on getting more public health professionals or public health centric workers into the government so that this could be more fully understood. And I'm sure there are efforts along the way, but there needs to be a unified effort for this. So hopefully, yeah.
Yeah, what do you think are the barriers for that? Why is it still not occurring? And how can they be overcome?
Barriers for this would be, well, as it is, the priorities of the government are not really on health right now. We have a health agenda, but in the Philippines, priority is shifted towards, well, more on the war on drugs and other aspects of the economy. So right now, it's pretty hard to shift health behavior because health behavior takes a really long time to change. That would be one barrier. And since our healthcare system is decentralized, you have multiple governing forces. So to get all of these under one roof would be quite a challenge. That's why we need more public health institutions or one public health association to really have a strong message. So more unity there. I hope that makes sense.
Yes, thank you very much, Sophia. We have a couple minutes left on our call. Thank you so much for presenters for keeping on time and presenting their very interesting projects. We can now go on our closing remarks. Back to Anahita.
Thank you, Mina. I think, Sophia, make sure you look at the chat because we have a fan saying "Go Sophie," and I echo Javier Torres in saying so. I cannot tell you enough the level of pride and hope that I feel today as I see 3 impressive examples of the next generation of public health and policy passionate professionals ready to make an impact on the world. So Giancarlo, Jiaying, and Sophia, thank you so much for working hard on your dreams, for having creative and innovative solutions, and for making your applications. As a time we want to do this in the long term, you will be the 3 first alumni of the Wise Incubator, and we want you to know that we will be here to help you in any way possible to advance these opportunities. Of course, I cannot tell you how proud I am that Policy Wisdom is able to have create this great platform to make a better world, and that soon we will be launching call for proposals for the 2nd year for the 2018 Wise Incubator. But I would be remiss if I close this without giving a few thank yous to the team. So first of all, to Mirna and to Andres Bartulovich, thank you so much for being the engine behind the Wise Incubator, making sure that everything happened. To Rodrigo and Andres Carballo for making it beautiful and that people knew about it and share with society. And then to Alida, Jordan, Maru, and Karina for being the coaches that work with the teams and that help with the review of all of the different proposals we received. So I'm very grateful for this, for having the Wise Incubator, for having the participation of our team and of our winners. And you know, let's wish that these policy initiatives become a reality and that we're able to make a better world. So hopefully when we launch next year, we can have some level of giving an update on where these policies and this effort has gone. So thank you so much to all. And it's right on time, 10 o'clock. So thank you for your participation, and we'll invite you for next year virtual conference. Thank you and goodbye.
Thank you. Goodbye.
Bye.
Thank you.
Thank you, everyone. Bye.
Thank you. Take care.
Thank you so much for the opportunity. Thank you.
Thank you.